Right. Good morning to all of you. At the foremost, I'd like to thank the organizing committee of the 10th Malaysian Hybrid Conference on Healthy Aging for the kind invite to talk on the topic of replacing joints for functional ability. Now, this topic refers to the joint-related disease and what we can do to treat it, including the option of surgery. So the time allocated is 30 minutes, and so let's get right down to it. I'd like to thank the chairman, of course, for the kind introduction as well. Now, right. Now, the topic, the table of contents of this presentation would start with the introduction, risk factors, stages and symptoms, X-ray features, treatment, and conclusions. The introduction, we will try and define what osteoarthritis is so that you have a better understanding of the issue at hand. When we talk about risk factors, we will probably be discussing on who's at risk, so we know who is more liable to suffer from this disease. Thirdly, we talk about stages and symptoms so that we have an idea about how decisions are made in the future treatment of this patient. And fourthly, X-ray features very briefly will be described so that we have an idea about how to assess the severity of the disease. Fifthly, we will talk about treatment, and treatment will outline what are the modalities of treatment the patient can undergo to counter this issue of pain in osteoarthritis, and a few words about conclusion as time goes on. Right. Who has it? Introduction. Osteoarthritis is a condition of the joint characterized by degeneration of articular cartilage and formation of new bone, that is osteophytes. Now, articular cartilage is a very special cartilage, and crudely put, it acts as a shock absorber and helps in the smooth articulation of the joint. About the disease of osteoarthritis, you find it is common in weight-bearing joints naturally because greater the weight, greater the force per square inch of area. So it's mainly common in hips and knees. You rarely hear about osteoarthritis being a part of the upper limb system. The lower limbs are usually affected. And who is affected? Both males and females are equally affected, but it's a little bit more common in women because of the menopausal stage that they go through at the age of 50 to 55, where the bone is now a little bit more osteoporotic as a result of the lack of estrogen protection. And so they are a little bit more prone to osteoarthritis. Risk factors, as this little cartoon shows, broadly, age is the first one, of course. As you can see over here, as you get older, we've probably used the joints a lot more. It's like a car breaking down after a number of years, So age is certainly a factor. The second one will be inflammation, such as rheumatoid or gout, which is an excessive, which can cause pain and inflammation, rheumatoid arthritis or gout. Thirdly, of course, you can have excessive BMI. Overweight is one thing, as mentioned earlier. Fourthly, you can have knee injuries causing pain. As earlier on, you must have had some sort of a traumatic knee injury as a result of sporting activities or excessive usage, or even an accident for that matter. So that can cause malalignment of forces, and this can lead to osteoarthritis in later age. Some of us are sometimes born with deformed knees, deformed hips, and because of the malalignment of weight forces, this can lead to arthritis as well. In Asia, we are a bit more prone towards sitting on the floor and squatting and so on. So these extreme range of movements can also cause osteoarthritis as time goes on. You don't see very much of this movement in the West, but in Asia particularly, we tend to use our joints a lot more in this fashion. And of course, repeated chronic strain on the joints as in very high velocity sporting activities, as in marathon running and contact sports and so on, can also cause damage. So usually we do find this in athletes and games professionals who basically come to us later on in age saying that arthritis of the hip joint and knee joint because of excessive usage in their younger days. They cause structural changes in the joint, and later this leads to arthritis. Now, the stages of clinical symptoms, can be very broadly classified. Stage 0 is, as you can see over here, this young lady is running around without any issues. It's perfectly normal, very well. Stage 1 is early or doubtful, mild joint pain with no serious symptoms and nothing that a little bit of a hot pack and foot rest, and she's quite okay probably after a couple of hours, a week or so. Stage 2, which is mild or minimal, is, well, it's trying to recognize that there is some pain in the knee joint. Sometimes when you're getting up from a sitting position, you have a little bit of pain. So that's the stage at which she or he is in. Stage 3 is moderate. And this moderate pain is when there's pain at all times as you're walking, when weight bearing, and you're consciously aware that there is something going on over there. And stage 4, which is quite severe, is when the patient is not able to do activities of daily living. We call it ADL. Is a little bit more comfortable sitting down most of the time, not able to go for shopping, go out, driving, and so on. So that's a stage at which normally most of our Asian patients come to see a doctor. Now, there are some cardinal features of osteoarthritis that are taught from medical school onwards. And these are some of the cardinal features. Decreased joint space between the bones, subchondral sclerosis. The subchondral zone is basically the area just below the joint line. Okay, this is the subchondral bone down there. Cyst formation, osteophytes, valgus, varus deformity. Osteophytes are extra bone formation. Varus and valgus deformities are angular deformities that occur in the joints. I have here a cartoon illustration of what a normal joint is and an abnormal joint. All right. On the left of the diagram is a representation of a normal joint. Now, bone here is of normal texture, whereas bone here is basically subchondral sclerosis going on over there, thickening of the bone, increased mass per unit volume, and so on. Then on the left, we have the normal thick, smooth cartilage, as you can see over here, thick cartilage, whereas on the right, you can see that the cartilage is thinned out. Joint margins on the left is quite smooth. As you can see over here, joint margin is quite smooth. But over here, the margin is very roughened out and the extra bone called osteophyte formation and so on. The space here is reasonably good, normal space. And on the right side, you can see it's either increased or decreased, depending if there's a lot of effusion, a lot of fluid accumulation, it increases. If there's fluid is decreased or there's not much fluid, and if the cartilage is worn off, then you find this area very, very thinned out. So those are the cardinal features, all right? X-ray features of the same. This is a normal joint, and this is an abnormal joint. That's the femur, and this is the tibia. You can see the joint space is even on both sides. The leg is quite straight. The borders, there's no subchondral sclerosis or cyst formation, quite nice looking. Whereas compared to this osteoarthritic knee, you can see that the joint space is severely narrowed here and on this side as well. There is a lot of extra bone formation, as you can see, irregularities is extra bone osteophyte formation. You can see that there is subchondral sclerosis just below the joint line and some cystic formation, cyst formation inside. So these are classic features of osteoarthritis. Besides that, you can also see, compared to the left side, the right tibia quite bent outwards. So it's a valgus knee. This is another feature of osteoarthritis. Again, another example, reasonably good looking knee down here on the left side. On the right, osteophytes, narrow joint space, sclerosis, and angular deformity. All right, it's facing inward. This is called a varus knee, where the leg is sort of bent inwards to the center of gravity. Now, this knee has undergone severe osteoarthritis as a result of a previous accident. There was a fracture of the proximal tibia down here, and you can see how deformed it is. It's also a valgus knee. It has got all these deformities going on. So it's another example of an osteoarthritic knee. Coming to hips, a few examples. I'd like to show a left reasonably normal looking. It's not exactly a fine hip over here. It's a reasonably good looking hip, a normal hip, so to speak. Look how well-rounded the head of the femur is and how well-rounded the acetabular borders are, all right? And it's a fairly normal hip. On the right side, you see how flattened around the hip has become. The hip joint has become, the head has become almost like an oblong hip with a lot of osteophytes. And look how narrow the joint space is. This is literally bone-on-bone articulation and causes severe pain, all right? So that's an arthritic hip joint. Another example, again, a normal hip on the left side. This is a fairly okay acetabular wall, which is looking all right. You can see the acetabular wall is quite normal. And look at this, but the acetabular wall has now protruded into the pelvic cavity. This is called, and then the head of the femur is completely deformed. It's no more round. And of course, the osteophytes and so on. So this is called an acetabular protrusio, also an arthritic hip joint. Sometimes patients have fractured neck of the femur. And when that happens, what we do is we try, especially the young, we try and save the head of the femur by putting in screws to fix them up so the head will hopefully reunite again with the shaft. But it may fail on occasions due to various reasons. And when that happens, it goes into avascular necrosis. The whole head sort of lyses away, and then you have these pins, these needles, these screws basically hitting the top end of the dome of the acetabulum and causing severe pain. We also do total hip replacement in these cases. Now, what are the treatment principles? Education is number one. We need to educate the patient. All right. The second step would be physiotherapy, aids, and appliances. Then we've got medical treatment by means of drugs and so on. And finally, when all options fail, there's not much of an improvement with all this, we go in for surgical treatment. Education. We need to inform, or we need to educate the patients, the relatives, and the carers. Because if you have a better understanding about the problem that you have, then perhaps you can deal with it a lot better. You can seek help in the right place at the right time. First thing is, see a doctor. Get the proper diagnosis. See an orthopedician. Get a proper diagnosis and a treatment plan. Secondly, be active. Physical activity eases pain. Simply because when one engages in physical activity, whether it's walking or slow jog or any physical form of exercise in terms of swimming and so on, or cycling in the stationary cycle, you find that you're secreting endorphins. And endorphins in the body are a good source of painkillers. So basically, it should be active, and physical activity eases pain. It also, besides that, it also increases your muscle strength, and muscle strength supports your joints. Therefore, that's another way of reducing pain as well. Thirdly, of course, weight. Now, weight, of course, is a big problem for all of us, trying to reduce weight, but it should be attempted because weight, the decrease in weight is markedly shown to improve pain, the pain factor. Fourthly, try and join some self-help organizations to learn skills at managing the disease. So there are many associations that help you deal with it. So it's good to look around, Google around and see if there's any that nearby your place. Join those organizations and see how best they can help you with your problem. Lastly, of course, to protect the joints. It would be good to engage in some lifestyle changes where if you were a marathon runner before, perhaps it's not time to do this anymore. You might have to go into some other alternative form of exercises. You probably have to switch to bicycling or maybe swimming as a form of exercise. So this way, you've got to protect your joints from trauma, so that less traumatic activities and try and reduce the pain that way. So these are lifestyle activity changes that are probably required. Coming to physiotherapy, aids, and appliances, we have got exercise, which is the mainstay of conservative treatment. What is not surgical is considered conservative. So we've been conservative in that we go about dealing with the issue. So exercises are very, very important. They're usually lifelong. They should be done regularly and systematically, and should be taught by a professional. Okay? TENS is basically transcutaneous electrical nerve stimulation. It's an adjunct. It can help to relieve pain and can be done by physiotherapists. Braces, splints, and mobility aids are also there. I'll give you a few examples. Okay, these are the exercises for joints. As you can see, stretching and strengthening exercises will help if done systematically, regularly over a long period of time. And this are usually taught by physiotherapists and rehab physicians and are usually very, very useful and our front line and a gold standard to start off treatment of osteoarthritic knees and hips. Then, of course, we do have TENS, as I mentioned earlier, and then you've got the rehab equipment as in walkers, walking frames and canes and applicants like this, where you crutches. These are also braces which help to offload the weight from your joint and help relieve pain. So these are very, very useful. They cost anywhere in the region between 200 to a few thousand ringgit, but they're very useful and a lot of people benefit. And sometimes it also helps to delay or even postpone surgery in the long term. Thirdly, of course, we've got medical treatment in the form of analgesics, intra-articular injections, steroids like hyaluronic acid. PRP is platelet-rich plasma, and chondroprotective agents. Analgesics, non-steroidal anti-inflammatory drugs, opioid pain medication. These are very good drugs that we tend to use for patients on a temporary basis, normally between 2 to 3 months with breaks in between, so that one can go through their daily activities and daily lives without any great pain. Okay? Then, of course, hyaluronic acid, which is injected into the joint. We also have steroids, and we've got platelet-rich plasma. Now, all of this are not guaranteed. It depends on when you use them and how frequently you use them. It usually is effective in those who are basically in the early stages of osteoarthritis. Once you get to stage 3 and stage 4 and so on, it's quite difficult that these drugs are going to be effective anymore. Steroids like this that are usually given once or twice a year are quite good to relieve acute pain, but they're not usually encouraged to be given too often, simply because they can cause osteoporosis of the bone, and then surgery becomes difficult in due time. Platelet-rich plasma is another one that's used. There are a lot of studies going on about it. Some centers report good results. Some are not very encouraged by it, but it's another one of those options that people have these days. Medication, of course, Adaxil, which is glucosamine sulfate, and chondroitin sulfate, which I'm sure you've heard about it, Vitril and so on, piacelidine, and then Atroda. These are different drugs that we have in the armament towards the treatment of osteoarthritis. Surgical treatment, now that's the interesting part. We come to this as a last stage where it's not effective. The earliest conservative measures are not useful or not helpful. Therefore, we have a few things that we can do under the surgical division. And first and foremost is arthroscopic washout and debridement. Osteotomy is the next one, followed by arthroplasty, which is a replacement of the joint per se. Now, what is arthroscopic washout and joint debridement? Just by means of 2 1-centimeter incision on either side of the knee, we could introduce a scope with a small camera at the tip, where you can see the interiors of the joint. And using a shaver through the other little 1-centimeter incision, we could go in and do a lot of procedures. We could debride, meaning we could clean up the joint. We could clean it up of debris from inside. We could repair the minor tears that are there inside. And some patients do feel a lot better after this. So that is one of the procedures that are available. Osteotomy is, there's sometimes malalignment of, this is the femur, the hip joint, and the malalignment of the bone can also cause pain. So what we do is we realign it by cutting the bone and realigning it and fixing it with internal devices, and patients can get some relief from that. Now, this is the knee joint where there's a malalignment. You can see how the tibia is severely in varus. We realign it by doing an osteotomy down there and fixing it, getting the knee to be straight, and that also helps in relieving knee pain. Because you see, in this malaligned knee joint, there's a lot of force being applied on this medial compartment, and that can cause severe pain. Here also, it's a knee joint, when osteotomy has been performed on the femur and realigned again with implants, as you can see over here. Those procedures basically help to delay a total knee replacement, and in some cases, probably even avoid. Okay. Now, coming to total joint replacement, the crux of today's talk is failure of where do we do it? Who performs it in the first place? Now, it's one of the subspecialties of orthopedic surgery, arthroplasty, just like your spine surgeons as an orthopedic surgeon, or your foot and ankle surgeons, a trauma, a tumor, pediatrics, and so on. We also have a specialist for the replacement of joints, and they're called arthroplasty surgeons. It's a recognized training program in the Ministry of Health and also in university. And we also have a lot of people who, despite not having gone through recognized courses and seminars, they have a lot of years of experience doing it. So there are many arthroplasty surgeons, both in the government, the university, and the private sector. Now, usually we will advise for a joint replacement to the patient if all the conservative management has failed. All right, and activities of daily living are affected, meaning the patient in distress. A gentleman who's able to go out in the morning for a walk is unable to do so. So those who've been going out, you can't go out to the grocery and buy your stuff. You can't drive. You can't get up in the morning and walk freely. So it affects your lifestyle. And so that's the time when you start thinking about doing something very much more effective towards relieving the pain. And of course, the constant pain and discomfort leads to distress, leading to psychosocial issues and so on. So that's when we advocate. No patient is ever forced to do a joint replacement. I would always say that a patient, or most of us orthoplastic surgeons, take on the view that you should have to earn your surgery, meaning you should have enough pain and discomfort to want the surgery yourself and not have a doctor tell you that you should have your joint replacement done just because it can be done. No, you should earn the surgery, and then there should be you should have some benefit, some profit from the whole process. Meaning if you had a pain score of 9 out of 10, then it should come down to 3 out of 10 or 2 out of 10 or 1 out of 10. So there's some benefit that you derive from the surgery. Right, arthroplasty is basically before and after. As you can see, that's what the joint looks like before surgery. And after surgery, we've replaced the femur, the end of the femurs with this implant down here, the femoral implants. In between out here, we've replaced with the plastic, a very specialized polyethylene plastic, and then another metal implant for the tibia. Similarly, the same thing with the hip joint. This is the stem that goes into the femur. You've got the round head over here, and then a cup that is actually inserted into the acetabular cavity. Normally, the metal component is basically a titanium or a cobalt chromium based alloy, and sometimes you can even use ceramic. All right. The plastic is a very ultra high molecular weight polyethylene with the various combinations. Okay, so it's the plastic is not just ordinary plastic that you just take off a shelf. No, it's a very specialized plastic. It's very high ultra molecular weight, so that it's polyethylene, and it lasts for a long time. So it's very resistant proof and so on. It does wear off, but it takes time. It takes time. All right. All right, here you are, another picture just to show you what it's like. This is how the head would look like, a femoral head with some liners and shelf and all that. And then you've got the stem down here. Similarly, this is the knee replacement with the polyethylene articulating surface in between. What's brought to the femoral component, the knee, and then of course the stemmed tibial plate. So this is what generally the whole thing looks like. Right, but having said that, there must be some pre-op conditions that have to be met. All right. The first and foremost thing is patients must have a realistic expectation after surgery. Well, if you were a very serious marathon runner, then perhaps after surgery, it may not be a good idea to go back to that because it's going to wear off the joint much, much faster. So you might have to do some other activities to keep yourself entertained. All right. So what I'm trying to say is that you shouldn't be thinking about, jumping up and down with this implant inside, because one has to take care of the implant to a certain extent as well. But you can walk. You can even do slow jogging. Should not be a problem. Secondly, before the joint replacement, one should attempt to reduce weight because that helps with the overall management of problems after surgery and also for the lifespan of the implant that has been put inside. You've got to strengthen the muscles well before surgery. You don't wait for doctors to decide. You start exercising, strengthen your muscles till the day of surgery so that after surgery, your recovery is a lot more faster and helps in early rehabilitation. If there's any general health issues like infections, a toothache or a fungal infection in the feet, those must be got rid of because any infection in the body can potentially run to the area where the implant has been put in and cause a total infection down there, which is not good. It's bad news for the surgeon and for the patient, of course. Diabetes and blood pressure must be under control, which is not a big problem because most of us by the time we're 50 and 60, we've got diabetes, blood pressure, and perhaps a little bit of gout as bonus thrown in as well. And those things are all fairly well controlled. You can always control that with drugs, which we do. So 90% of our patients have diabetes and blood pressure. Not a big issue, can be controlled well, and surgery can go on smoothly. So to any other comorbidities, any other issues that you have health-wise, you've got to attend to that as well. Right, what's the process? The process basically for a patient is we are admitted a day or two before surgery to the hospital, sometimes on the day of surgery, all right? An explanation is given as to what the process is all about and a consent taken from the patient. Preoperative x-rays are taken so that with the x-rays, the surgeon and his team will template it, plan on what kind of a size it is, what kind of size implants, tibia, the femur, has to be put in a acetabular cup. All that is decided prior to the surgery, not at surgery. so that we have a fairly good idea about what we need to expect and what we need to keep ready for surgery itself. The pre-op anesthetic review will be there. Anesthetist will come around. He will examine you for all your systems, make sure you're quite safe, your lungs are okay, your heart is okay, your kidney function is good, and then leave you with some instructions about that you shouldn't be eating after 10 in the night, and we'll give some medication to relax the patient and then go away. And the idea would be to give either spinal or general anesthesia. Now, spinal anesthesia is an injection of the back, and one doesn't feel anything below the hip joint, but is aware. But normally, just so that the patient doesn't get anxious, they will give some sedation and the patient sleeps off. General anesthesia is when a tube is put into the trachea, and then the machine takes over, and the patient doesn't know anything, and then he recovers after the surgery, and all is fine. Peripheral nerve blocks are usually given in some centers, not very commonly done, but there are some centers that go just nerve blocks, and then surgery is carried out as well. Now, total joint replacement, what do? We replace the worn-out joint with metal and plastic. The skin incision in a hip joint for hip surgery, hip replacement, is about 10 centimeters, just above this is the buttock region, this is on the lateral side of the hip, all right? And for a knee, it will be about, again, 10 centimeters, and this is what it roughly looks like. This lady has got bilateral knee joint replacement done. It's about 80 centimeters long at the most. And the operation would last anywhere between 90 minutes, maybe even less in some cases, to 180 minutes, or even longer, depending on how complex the case is, all right? The straightforward case will be in less than an hour or an hour and 15 minutes and so on. Okay. Right. The post-op, operatively, the patient is moved on after surgery to the recovery bay, monitored for stability of lung and heart function and so on. Pain management will start very soon as the patient is wheeled into the ward. Physiotherapy will be on the first post-operative day, just about maybe 24 hours after surgery. The physiotherapist will come and teach you some exercises, what should be done from then on, short-term and long-term exercises. The patient should be able to sit, stand, and walk 24 to 48 hours later, probably with an aid, a walking stick or a walking frame. So the patient gets a feel of the new joint, gets used to the proprioception, the new proprioceptive senses that he or she will feel after that. And it takes about 2 to 3 weeks on this walking frame before the patient feels at ease to walk on his or her own terms, without any aid and so on. We usually discharge the patient by the fifth post-operative day, if not sooner. We don't want the patient to be in the ward for too long because of fear of picking up other hospital-borne infections. So we try and send them off as soon as possible. Right, the stitches are removed within 2 weeks. Normally, some of us will follow up the patient on the first month, third month, and sixth month, then perhaps yearly for about 2 years before discharge. After that, there's no issues. The patient can always come back and see the surgeon if he's got any issues, even after that period of time. Complications in any center in the world, complications will range from 1 to 3%. All right. So what are the complications during the operation itself? Because quality of bone may not be so good in some cases, especially the very elderly with osteoporotic bone and so on. There can be fractures, but surgeons generally know how to fix it. They fix it by screws and plates inside so that they can bypass the problem. All right. That's why I think one with some experience, a certain amount of experience, should be doing these cases because they can meet the challenges that one meets on the table. Secondly, bleeding, excessive bleeding. But we do use a tourniquet for knee operations. But in some cases, there can be some excessive bleeding, but which can be countered by transfusion of blood and so on. Doesn't happen very frequently, but these are some of the expected or recognized complications in surgery. Deep infection that occurs immediately or even post-operatively within 2 to 3 months and so on, that is a nightmare. Now, we take all absolute precautions in the way we do the surgery with sterility measures. Not too many people are allowed into the theater, and so there's no air turbulence. Everybody gowns with the strictest sterility measures being taken while draping and so on. Therefore, these are usually kept to a minimum. But deep infection means the infection we can either treat with antibiotics after hospitalization, or in the very rare cases, on rare instances, we may have to take the entire implant system out before we put in a new implant. But it doesn't happen very frequently. It's about 1 to 3% at the most in any center, recognized center. Stiffness after surgery is a possibility, but physiotherapy can step in, and we do a manipulation under anesthesia so that we can increase the stiffness that might occur. But exercise is primarily very important to counter this problem. I'll give you a few examples of hips hereafter. First case of osteoarthritis. Right, you can see out here the hip joint. This is a fairly normal hip. On the right side, this hip, you can see how narrow the area has become with sclerosis and a deformed head. That hip was replaced. That's what it looks like after replacement. You've got a cup inside, a head, and a stem which has been cemented inside. This is post-operative. Now, bilateral hip avascular necrosis. Some cases where, especially those who've been on drugs, especially drugs that have got steroids in them, like an asthmatics, inhalers, or long term. That's one reason why you can have a complete collapse of both heads of the femur. You can see how deformed the head is. And this is called bilateral avascular necrosis. It can happen on one side or on both sides. Here you can see it's happening on both the sides, right? So it's collapsed and severely painful. So in these kind of cases too, we've done a hip replacement here on the left side. Right side has not been done as yet. And the patient is pain-free now. Sometimes you can also have a neglected fracture neck of femur. Patients have had fracture neck of the femur like this and neglected it, which means they say, no, it's not severely painful, I can walk. But they come to you years later with a neck, with a head that is actually displaced. You can see the femoral shaft having moved upwards, and the femoral head having undergone AVN. And this is painful. It gets to be painful after a certain period of time. So what have we done here? We've gone ahead and replaced it with a hip replacement. Patient's quite okay and able to walk quite well. For example, examples will be severe bilateral knee osteoarthritis. This is a typical case. You can see how badly deformed the knee is on an AP view and a lateral view on the right side. This is the left knee, also severe, a lot of osteophytes, extensive osteophytes. Now, this is what I meant by templating. We draw it off on a board and on Chinese paper, we have this tracing paper, we draw the outline there and we put the image of the implant out there. We draw that out and see what sizing. We've got all the sizing done, the angles calculated. So this is a pre-operative planning that we do before we go in for surgery. Well, this is what the patient looked like on the table. You can see how deformed the left knee is and the right knee because both are pretty severely osteoarthritic. She's, I think, somewhere in the 70s. Well, the left knee was replaced with an implant. As you can see, there's the AP and the lateral view. You can see the difference now. Now, I'm trying to illustrate here that a bent knee now has become a straight knee on the left, which is operated. The right knee has not been operated as yet. So that's the front view, and this is the back view. This is the left knee that was operated, quite straight and fairly okay. The right knee is still in varus, deformity. So we went ahead and did the right knee as well. That's the AP, and that's a lateral view. There's the right, there's the left from the front. So both knees have been done. That's a lateral view of the right knee and the left knee as well. Now you can see both knees, how straight it gets to be and how much you can bend, about nearly 120 degrees. Quite comfortable. I have a little video here. I wonder if it plays. Yep, let's see if it plays. Right, so she can walk reasonably well with both her knees done, and she wasn't able to do so before that. So that's one of the reasons. Okay, this is another knee of right knee. You can see how bad there's hardly any space in between, and the patient is in severe pain. That's the AP view and the lateral view. I've got a little video of this lady walking. Okay, that's done. I'm sorry. So we went ahead and did a replacement for her. She was just in her 40s. So the right knee was replaced with this implant. The total knee replacement was done. And you would see that this is her walking just about 5 months, I think 4 to 5 months after surgery. I'm trying to illustrate here that a lot can be done. A lot can be done with surgery for very deformed knees. And the results are quite good, done by an experienced arthroplasty surgeon. And the pain can completely vanish, if not partially. But you can still have very good results, and you can walk reasonably well. So it's not a hopeless situation. That's the point I'm trying to make over here. Here's another case of a gentleman with bilateral severe osteoarthritis. You can see how bent the knees are. And I haven't got a video of him walking, but he waddles like a duck, literally. After the left knee was done, you can see the scar mark over here. Left leg has become quite straight, and the right is still bent. So we're going to do the right side, but before that, the COVID era struck in, and so we are stuck. So we're waiting for things to clear up before we do the right knee. Okay, all right. This is the knee of an elderly gentleman. This is the one that I just showed earlier. There's the left knee that is done, and it's quite okay. This is the X-ray of the patient before surgery. So he has got this implant inside him, and it's quite straight, and he's pain-free at this point in time. The third case, people tell me, I'm too old at 70 and 80. Why operate? I've just got a few more years left. But you never know how long you're going to live anyway. So I think it'd be a good idea to go ahead and do what you have to do to improve the quality of your life. Because after all, it's about quality of living, And this gentleman, a knee replacement, was a 96-year-old male. And this is what it looked like after surgery. You can see a scar mark down there, extension and flexion. And he's still around. This was about 3 years ago. He's, I think, almost 100 now. But he's quite a sprightly gentleman, still very active and so on. A knee replacement was done, 96 years old. Okay. So, in concluding, some post-operative precautions. After surgery, one of the things that you've got to be careful about, systemic infections. If you've got a boil or an ulcer or a throat infection or a fever, a dental infection, so on, you've got to actually seek treatment quick, because there's every chance that the bacteremia that it develops, that one develops, can go and seek the implant and get stuck onto that area and cause massive infection of the joint, and that can be a failure. So systemic infections, seek treatment early. Avoid falls, obviously, because one falls, you can have periprosthetic fracture just around the implant itself. So you've got to be careful about avoiding falls. You've got to get a sense of balance and so on. And extreme flexion, as in hip, don't sit on a very low stool and so on, because that will be very good. It can dislocate. So, of course, now with the modern implants, dislocation is quite not very often, can be avoided with proper surgery, lesser the chance, but still one should avoid that. And knee flexion, one may not be able to flex up to 130 degrees, maybe 120 or 110, but not 130. It may not be the same as before, because nobody can replace nature or God the way it was intended by doing, these artificial joints. But sometimes you've got to accept certain limitations in the range of movement, hip, like I said, the hip, low chairs, excessive adduction, cross-legging, those things should be avoided in the first few months, first year or so at least, so that the muscles get stronger, they become more stable, and the joint does not dislocate. So those are some of the things precautions that one has to take. All right. How long will it last? Well, hips can last between 50 to 25 years. There are cases where it lasts up to 30 years also. And knees, of course, 20 to 25 years, if not more, if taken care of well. By which time, of course, usually our lifespan would have finished. That lifespan is still on, so it's not a big issue. But if it does wear off at a time when you're still active, then of course a revision surgery is performed, and that helps. That helps to put in another implant. It may be a bit more complex, but it can be done. A lot of revision surgery is carried out all over the world and in this country as well by very good orthopedic surgeons, arthroplasty surgeons. Well, thank you for your patience. I do hope that you've got a sort of a general overview about what the arthroplasty is and what you can do about joints that are not very functional, that are painful and causing changes in your lifestyle. Thank you very much.